We've talked a lot in my lecture about diagnosis of pneumonia. I'll start first with community-acquired pneumonia. There's a lot of new information that's coming out. The first point we highlighted was part of the limitation of the use of the chest x-ray. A lot of studies have begun to show that the chest x-ray is imperfect for diagnosing patients with bacterial pneumonia that requires antibiotics. Some studies have suggested additional diagnostic tests like CT scans may perform a little bit better, but I don't think are a routine part of practice as of yet. I placed a lot of emphasis on a physician using their clinical skills, evaluating the patient using clinical judgment as to whether they think it's pneumonia or not, and recognizing that in some cases they may think it's pneumonia and the chest x-ray may be negative, and it's still a patient that may warrant antibiotic treatment. The other thing I think it's important to focus on and think about with what's new, a lot of information is out there on the use of a biomarker called procalcitonin in diagnosing patients with pneumonia. And I think the bottom line with respect to that test is it is a potentially useful but imperfect diagnostic test. I think it is useful for doctors working at institutions that perhaps are struggling with very long treatment durations for their pneumonia patients and are trying to find strategies to reduce over-treatment of pneumonia, and several studies have looked at using a procalcitonin and following it serially can help reduce treatment durations. I think it's important we highlight the limitations of that test. It is not a perfect diagnostic test, and what I recommend to physicians is if you're convinced this patient has a serious bacterial pneumonia needing antibiotics, don't even send the test to begin with. Just go ahead and treat. Similarly, if you're absolutely convinced you're not going to treat and the patient does not have pneumonia, don't send the test, don't treat. But if you're on the fence, it may actually be useful, but should not be a standalone diagnostic test to make a decision, does the patient need an antibiotic or not. We also talked a lot about the role of antibiotics and what are the big controversies or issues with antibiotics. One big one is do we need to routinely add macrolides onto beta-lactams for all hospitalized patients with pneumonia? And I think the bottom line there is that most of the data suggests that for sicker patients, critically ill, maybe perhaps the severely ill ward patient, the literature does suggest that the addition of a macrolide adds benefit to the beta-lactam. But there are probably subsets of ward patients who are not critically ill, in particular those who do not have risk factors for Legionella or have had testing showing they do not have Legionella, where the beta-lactam alone may be beneficial.